Hello and welcome to Frequently Asked CCM Billing Questions, a ChartSpan Medical Technologies webinar to address common questions from our clients. My name is Shannon O'Neill, Director of Client Success at ChartSpan, and joining me today is Don Self, our go-to billing and reimbursement expert. So Don, if you will, tell everybody a little bit about yourself and what makes you our expert.
Well, hello, everyone. I've been consulting with physicians on reimbursement issues for 35 years, taught a little bit over 600 webinars and seminars, and I'm published to somewhere between 40,000 and 70,000 offices every month in different magazines and publications.
Perfect. Well, I couldn't have said it better myself. So with that, we'll launch right in. So we're just going to go through a series of questions that are commonly asked by clients. And then, of course, we don't have to read verbatim. Clients can read these on their own. So I'm going to leave it to you to just kind of ad lib as we move through and make sure that we fully address these.
Yes, ma'am.
All right. So our first question is, just for traditional billing practices, what code should they use for CCM services when they bill monthly?
Most of the time, you're going to bill out with code 99490 once you've spent at least 20 calendar minutes in the month working on the chronic care plan for the patient. There will be times when you're going to bill out 99487 if the number of minutes equates out to it, which is higher payment than it is for the basic code 99490.
And for those codes, so you're referring to the complex codes, will those actually require any physician time?
Medicare has said at one point back in 2015, they expect the doctors to spend about 15 minutes a month on this themselves. But since then, the data that Medicare uses to calculate the relative value units has not actually included physician time into it. So I don't believe that you have to have the physician active involvement in order to bill out either the 99490 or the 99487.
Oh, wonderful. And our next question is going to be for our RHCs and FQHCs. ChartSpan has about probably 2/3 of our client base listed as RHC or FQHC designation. What code would you recommend that those designations use for CCM services?
Well, let me clarify by saying that I'm not a rural health clinic specialist. I want you to make sure everybody understands that. I am pretty amazing when it comes to physician offices, primary care offices, but from everything I've studied on rural health clinics, it's going to be the GO 511 code there that it's showing on the screen.
Perfect. All right. Thank you, sir. And then for RHCs, this is a common question. RHCs, sometimes FQHCs are used to billing as that all-inclusive rate. They get higher reimbursements. It's a fantastic opportunity to bank on CCM services. However, is that something that RHCs and FQHCs can do with CCM?
Well, they can't bill out for they're not going to get paid their normal $86 or $200 amount, depending upon if they're independent RHC or provider-based hospital-owned RHC that they're so used to getting. But the amount that they're getting at $66.77 is about 50% more than the standard code or the standard rate that fee-for-service physicians are getting. And it's so easy to do it. And on top of that, right now with the COVID-19 emergency going on and the public health emergency going on, Medicare has made additional relaxation of the rules when it comes to RHCs or fee-for-service clinics doing chronic care management, so that everybody should be jumping on board that right now.
Indeed. Thank you. How about billing, and this is for traditional practices, how about billing TCM and CCM together? That used to be a billing conflict. Is that still the case?
It's not still the case any longer. In 2015, when Medicare started paying for chronic care management, they made the statement that you can't bill out TCM and CCM in the same month for the same period. Well, too many people misunderstood what they meant by same period. So if it's a certain number of days that is in part of the transitional care management, the 7 days or the 14-day period, then during those 7 to 14 days, you can't bill out chronic care management also. But keep in mind, there's 30 to 31 days an average month. So that still leaves us around somewhere between 21 and 14 days that you could be doing chronic care management on it. So they both can be billed.
Wonderful. That's a relief to a lot of clients for sure. And
Good.
do patients who are in CCM program, for example, let's say a patient has consented to the program, they've enrolled in the program, is it necessary for them to actually see their provider every single year or on routine visits once they've enrolled in the program?
It's not required by Medicare that they see them every 12 months as long as the doctor has seen the patient in the previous 12 months. And right now again, I'm going back to the COVID PHE right now because there's so many rules have changed in the last 70 days due to the COVID changes and emergency that's going on. Medicare is allowing doctors to be able to do an audio video with the patient if they have not seen him in 12 months prior to the initiation of the chronic care management. So again, once more, everything is changing right now temporarily, but everything that's been changing has been for the best, for the good. I'm excited about everything going on right now with telehealth, telemedicine, chronic care management. It's all exciting to me.
It's about time we get some of these positive changes, right?
Amen to that. And I think there's going to be other positive changes out of the entire COVID thing, like the telehealth that's going to continue after. We don't know how much of it will continue after, but I don't believe that they're going to be able to put this toothpaste back into the tube. I mean, they've let it out. I don't think they're going to get all that toothpaste back into the tube when it's over. So I think we're going to continue to get to do telehealth when it's all over.
We would love some progress.
Yes,
I have
ma'am.
another question for you. This is regarding CCM again. Is there a requirement that ChartSpan or a vendor or even a practice speak to patients every month while they're in CCM in order to bill for CCM?
No, ma'am, and that's probably the biggest misconception that most people have, including the patients. The doctors, the staff, the patients, they all seem to think that only the time that they spend on the phone with the patient gets to be counted. So you might have a patient be billed out for chronic care management and call up the doctor and say, "You didn't talk to me. How did you bill?" Well, the doctor's staff may be thinking that they don't get to bill it out because they didn't reach the patient for one reason or another. It's just the total amount of time that's being spent that month on the management of the chronic care plan. And that could be the entire 20 minutes or 30 minutes or whatever it is that you're billing could have been spent on drug reconciliation or calling other caregivers that the patient's seeing, contacting their rheumatologists, their orthopedic, their cardiologists, their urologists, all the ologists that's out there, and asking them what drugs that they're giving the patients. And not even actually reaching the patient, you still get to bill out chronic care management.
It's a great point. What other services that you know of are billing conflicts for CCM? This is a common one as well.
Yeah, because a lot of times people sit there and say, well, I can't bill out chronic care management if the patient's getting home health certification. That's not necessarily true. Now, if you are the home health care supervision and you're billing out the G0181 code that requires 30 minutes of that, then yes, you can't bill that and chronic care management together. But if you're the family doc or the internal medicine doctor or whoever, and you've signed the 485 form saying this patient qualifies for home health certification, then that's totally different. You're billing out the G0180, and that's about $50 for that around the country. And then every 60 days, you bill out for the G0179. You can do that and the chronic care management at the same time. You can't count the same minutes you spent signing this form towards the 20 minutes that you're billing out for chronic care management. And as it says on the screen, you've also got hospice care supervision, dialysis care. So those kind of services are bundled into it, which is why I always recommend any billing person double check the NCCI edits, National Correct Coding Initiative edits. And CMS has those on their website. I have them on the donself.com website, so you can click in there and see, does this code allow me to be billed with that code in the same month? And if it says never, well, there's your answer. If it says yes with the right modifier, go for it, as long as you've done your documentation.
What an excellent resource. Thank you, Don. I'm going to add that to our conversations with clients going forward.
Thank you.
Absolutely. Thank you. Can providers bill for CCM more than once a month?
No, you really can't because it's a 30-day, it's a whole calendar month period. So what you're going to do is, I typically recommend you wait till the end of the month and then figure out how many minutes you have so that you can figure out, am I billing out for 99490 or 99487 or 99489 or which code? So you want to wait till the end of the month and calculate it, but you're only going to bill out to chronic care management once for a month.
Right. Perfect. And how long do you have to file a claim for CCM to Medicare?
Medicare, and a lot of people don't understand this, but Medicare has a 1-year filing period. During President Obama's term, he did a change on that and made it 12 calendar months for all Medicare Part B. Now the question comes up, what about Medicare Part C? Well, Medicare Part C or the Medicare Advantage plans, each has their own timely filing period that you have to follow for their plan. So United Healthcare Advantage Medicare, Blue Cross Advantage Medicare, Cigna Medicare, et cetera, all of them have their own plans, so you have to find out what those are. But Medicare Part B is 12 calendar months, so it's 365 days.
What date of service? This is a good one too. We have different things that are happening at the practice. For example, if the patient was in to see the provider, or maybe they were in the hospital, what date of service is best to use for CCM, for a CCM claim?
I know some offices, as soon as they've hit the 20 minutes, they file the claims. And to me, that is a nightmare to the billing person. Your billing agency, billing person that's in the clinic, it makes it so much easier if you wait till the end of the month, total up how many minutes you have for that month, and then maybe a couple of days before the last day of the month, just file them all out for that whole calendar month. Keep it simple, and if you keep it simple, people will do their job. If you make it complicated, things will get lost.
Indeed, we find that often, huh?
Yes, ma'am.
Here's another good one that we get pretty frequently. What provider types can participate in CCM?
Well, typically I'm telling every one of my MDs, DOs, I'm telling my nurse practitioners and PAs, and you can also have certified nurse midwives and clinical nurse specialists do it as well. But the other ones, such as the podiatrists, the chiropractors, et cetera, like they're not allowed to. They're not they're not considered to be a CCM type provider according to Medicare.
Psychologists, behavioral specialists, social workers often work so closely with patients. So I'm sure that is a little bit of a conflict.
It's a little bit of a conflict, but at the same time, if they're working in conjunction with a physician and billing it out under incident 2 for the physician that's in the clinic, that the physician that ordered it, even though it may be performed by one of the other type specialists, then you can bill it out. But it would be billed out by the practicing physician or a nurse practitioner or PA.
Right. Okay. Perfect. Can nursing home patients, and we just talked about this, can nursing home patients also enroll in CCM? I think the concern there is often double dipping, or, they're already receiving nursing service or care. Why would we do CCM on top of that? And we really try to encourage people to understand that there's so much more support that we can provide, even to the home health nurse or specialist who's going in to visit.
And there's a big difference also in the type of facility. Whether it's a skilled nursing facility, place of service 31, or is it a domiciliary? I always have trouble with that word. How about domicile? Domicile facility, that's easy for me to say. Assisted living facility, which is also called an ALF. They can be billed out for this right here. Well, those places of services can be billed out for the chronic care management. And as you pointed out, by having the folks that's at the like chart span nurses handling all the calls, instead of the nurse calling the doctor or the MA, whoever is at the assisted living facility, calling the doctor every time the patient passes gas or wants a Malox, it makes more sense for them to call the nurse that's taking care of the patient's chronic care plan for the doctor and let them handle it for you. And so I'm a big believer in that. My own father-in-law, for instance, is at an assisted living facility. And right now, during this lockdown period, they'd only let him out of his apartment one time a day for about 10 minutes. I think they put a leash on him and take him for a walk. Okay, maybe not a real leash, but that's what I joke with my father-in-law about it. Them,
I'm
them
sure it feels like it.
taking the geezer for the walk today, and I shouldn't say too much because I'm only about a year away from Medicare, and then I'll be classified as a geezer too. So
No way. No way. All right. So we talked about nursing home patients. How about home health patients?
oh, big time. That, as I said before, just because you're certifying the patient for home health by signing the 485 form and you're billing out the GO 180 or the GO 179 for the research, does not mean you cannot do home health also. The thing is, you cannot be the home health supervisor. In other words, you cannot be billing out the GO 181 for spending 30 calendar minutes in a month at the same month, uh, as long as you're billing the chronic care management. So.
Perfect. Well put. So can we also bill for CCM on the same day as a hospital or a provider visit? How would that work?
You can. It's just sometimes if you stick to both of them on the same claim for the same date of service, the individual in Medicare or commercial insurance carrier, they make up their own rules and they may require you throw a 25 modifier on the office visit code or the E&M code. Then the 25 basically says that the visit was significant and separately identifiable from the CCM being billed on the same day. My advice is make it simple. Let your billing people bill out the CCM towards the last couple of days of the month, and just go ahead and bill out the E&M visits on whatever day you do them. Keep it simple and clean.
Nice. All right, this is a good one. This one's for you, Don. Can we bill for CCM and RPM during the same billing period?
Well, this gives me an opportunity, as you well know, to talk about OPM, which is remote physiologic monitoring. It's also considered to be telemonitoring. Now, a lot of people get confused about telemonitoring. They think, oh, is OPM the same thing as sending home a continuous glucose monitor? No. Is it the same thing as sending home a Holter monitor on the patient that they're wearing or a 30-day cardiac event monitor? No. Those are separate. RPM, or remote physiologic monitoring, is where you might be sending home a blood pressure machine, where the patient's going to be checking their blood pressure daily, and every time they do, it gets transmitted to a receiving station that the doctor's staff will be checking on a regular monthly basis. Medicare loves this. They love telemonitoring because it saves them a fortune. Just like Medicare loves chronic care management because it saves them a fortune. Medicare's whole concept, and I'm gonna do a little preaching right here, so you can turn in your Bibles if you want to, whether or not it's an NIV or KJV or whatever you're using. The Medicare loves it because if they're able to capture these illnesses and problems at an early enough stage, they can stave off or totally eliminate sometimes the catastrophic care. And with Medicare spending $30,000 to $60,000 on a typical hospital stay, or $3,000 to $5,000 on a typical ER visit, overall for all the services they pay for, it makes sense for Medicare to be able to pay for the $100 and something a month for remote physiologic monitoring, or the $40 to $50 or $70 a month, depending on if it's a rural health clinic, et cetera, for the chronic care management. So yes, they can be paid in the same month on the same patients. I have a lot of my clients using RPM and chronic care management through ChartSpan, by the way, uh, in the same months. But then, in fairness, I need to tell you, I also own an RPM company that we rent equipment to doctors on a monthly basis. So that's, I believe in transparency and telling you why I'm so, what's the word, passionate about RPM.
That's why you're the expert.
Thank you.
Here's another one for you. So this is outside. We're finished with our CCM questioning for this webinar, but there is a rising need for capturing AWV visits. And I was thinking with your telehealth information, maybe you could help us out a little bit with AWV compliance and helping clients to capture those AWVs via telehealth.
I'm more than glad to. In fact, as you brought up all the telehealth stuff, and this week I've taught 3 telehealth webinars. I've got 7 scheduled I'm doing next month in June for different coding chapters and independent physician associations around the country. So a lot of people don't understand annual wellness visits has been around since 2011. Unfortunately, most of the doctors out there are not doing annual wellness visits the way they should or when they should. If I pull up the 2-year-old data that I have right now from CMS, and I'm waiting for the last year's data, hopefully to come out soon, then I'll find out that only about between 12 and 14% of Medicare patients in the country were getting annual wellness visits. And it's because only about 7% of physicians in the country are doing Medicare annual wellness visits. The physicians have no idea what the benefit is to the patient and why Medicare wants every Medicare patient to have a wellness visit, AWV, and that an annual wellness visit is not a physical. I know I'm preaching again, so if you give me a good amen once in a while, I feel comfortable standing here at this
Do the
pew.
choir.
Okay, good. So you really want to make sure you're doing annual wellness visits. And during the telehealth period right here, Medicare, first off, has been allowing you to do annual wellness visits via telehealth since 2018. It wasn't until April 30th of this year that CMS published 244 codes on an update for the telehealth period right now during the emergency, that out of those 244 codes that you can do via telehealth, 91 of them you can do via telephone only. And Medicare added annual wellness visits to that list of services that can be done via telephone only. Now, the question comes up, and in fact, less than 2 hours ago, I was having a conference with someone about how to do annual wellness visits via telephone. Because they sit there and say, well, how do you get the vitals? Well, last night, which was Thursday, May 21st, CMS had their call with thousands of people around the country, and they were asked that very question. How can you do the vitals during the annual wellness visit
We
on a
all want to
telehealth
know.
call? Everybody wants to know. They said you can ask the patient. And I mean, I can ask the patient, has your height or weight changed? Exactly. And if the patient has a blood pressure, and by the way, most people with hypertension, like I am, has some kind of a monitor at home. I can do my own blood pressure while I'm talking to the doctor on the phone, or I'm talking to the doctor's nurse on the phone. You sit there and say, well, how does that work with ChartSpan? ChartSpan has an amazing AWV program that a lot of my clients are using around the country. And again, I want you to understand that I'm going to find what's best for my clients regardless of who is providing it. That's just what I've been doing for 35 years, and ChartSpan seems to be the best in everything I've seen on that. So they will have the patient on the phone with a nurse or an MA in the doctor's office doing this, and they're answering the questions on the iPad that ChartSpan provided. They've already done an eligibility check on the patient to make sure that the patient qualifies for the annual wellness visit, because we don't want staff doing something that we're not going to get paid for. So by doing this, you can find that not only can you do the annual wellness visit via telehealth now using ChartSpan's technology, but you're now going to be able to get the additional MIPS scores from doing the annual wellness visits and doing the chronic care management. And that's another benefit that we didn't even talk about. Are you going to be asking me at all about MIPS today?
I think that's the next webinar, Don. We
Oh,
can go into that
okay.
for hours.
We can. Forgive me, I get very winded. I teach one and a
No,
half to 2 hour webinars, and I get carried away at times.
this
But
is
I
great
love this whole
information.
subject. Thank you.
This is awesome. We were thinking that too, especially for AWVs, if we were doing AWVs via telehealth, is it a 95 modifier?
Yes, ma'am. Anything you're doing right now with via telehealth is a 95 modifier. And I'm glad you bring that up, because some billing people, well, coding experts, and I'm a certified medical coding specialist. I'm also a certified professional coder, so I speak at the different AAPC chapters. In fact, this week I've taught 2 for chapters, and I've got a bunch scheduled for next month. So I'm very comfortable at telling coders the 95 modifier is going to go on the services you're performing via telehealth, such as the annual wellness visit, GO439 with the 95 modifier. And you may be asking, but what if I do it via telephone only? Doesn't 95 say interactive audio video? And yes, it does, but CMS has said they still want you to use a 95. And remember, CMS's rules and AMA CPT rules are sometimes different. So since CMS is the one paying for it, we have to follow their rules. He who has the gold makes the rules.
Excellent. Thank you, Don. That is why you are our go-to expert.
Well, thank you so much. I feel honored to do this with y'all.
Thank you. So this is the end of our webinar today. And if you would like to contact any of us, we'd be delighted to hear from you. We recommend that you reach out to your client success lead, and then we'll connect you with Don if you'd like to chat more about some of these options and see how he could help your business. Feel free to let us know if you have any questions at any time.
No
Thanks so
matter
much.
what you need, you holler at us. And one piece of advice for everybody. During this COVID emergency, don't lick any doorknobs.
That's sound advice, Don. Thank you.
Yeah, but thank you. Bye-bye.
Bye-bye.